My dear friends, ladies and gentlemen, welcome to our SEM Endoscopy Masterclass. Today I am going to share with you very important topic, complications of upper GI endoscopy. This is a very important topic, especially if you are beginning in the career as an endoscopist and you are in the level 1 training. Please see that all these complications can be easily prevented, or even if you see it, how to manage. So, because all of us should have a good training to make sure that whatever happens, we call it as unplanned events, that is, despite a good care and treatment, if complication happens, anybody can have it. But if get into trouble because of your poor standard of care or treatment, then the court may see it as a negligence. So, we do not want to get into the stage of negligence. In order to do that, a good training is a must and all the protocols have to be followed. The first important thing I wanted to emphasize is the importance of the informed consent. If you have a patient waiting to have an upper GI endoscopy, ensure the patient gets a sufficient information and are able to understand and voluntarily give a written informed consent, that is you call. You give them all the information, why you do, how you do, and what is the outcome of the procedure, like benefits and risks. If the risks however small, like a perforation, admission, or even a rarity as need for surgery, you have to mention in the all the information leaflets, so that the patient can ask you all the questions, convinced that it has to be done and it is absolutely essential for him to undergo, then it will become a legal document. So, better you get a very good informed consent, preferably in the patient's own language, depending upon whatever regional language you speak. Coming to the complications as it is, endoscopy is essentially a diagnostic procedure. We do not expect a major catastrophic problem, but still sometimes patient can get into what I call a cardiorespiratory events, especially arrhythmias, MI, hypoxia or aspiration. And these, how to avoid, all patients coming to the endoscopy room ensure they have a venous access, they have a pulse oximetry, they are administered nasal O2, so that oxygenate the patient, so they do not go into hypoxia, and ECG monitoring, especially when they are having a comorbid illness like history of hypertension, ischemic heart disease, or MI with the stents placed. The second incidence you need to aware is when you are going to administer any drug for that matter, the patient can get into any allergy or adverse effect because of the drugs. Normally, it is quite a norm in diagnostic endoscopy, we used to give midazolam. My opinion is, if you are going to give a midazolam, ensure the patient has a venous access, give not more than 2 to 3 milligrams, that is sufficient enough to become an anxiolytic agent, so that you will be able to do a endoscopy comfortably. It is not analgesics. If you do any painful procedure, you need to along with that you may have to use other drugs like a tramadol or more powerful analgesics later if required, but only in the presence of the anesthetist. The second thing is xylocaine 10% spray can be administered, provided it is given at least 5 minutes before, 2 squirts, to minimize the gag reflex. There is always a theoretical risk of infection if you do not rigidly adhere to the disinfection protocol, and we have to have always a universal precaution, like I have the impermeable gown, specs, mask, double glove, all those things are essential. Then there are some units they have routinely performed like a viral marker study in everybody walking through the door of endoscopy. But what is more important thing is, if you know already this patient is HbSAg positive or HIV infected, those cases can be kept as a last or fag end of the day, they can be done. That is the additional advantage of doing all this test, but I think this is institution based investigation. I do not think it is absolutely necessary, provided you take a universal precaution, strictly follow the disinfection protocol. Let us discuss in detail about the more major complication later, but let me address a very important issue. The failure to diagnose or treat or failure to recall a patient is a very important aspect I want to highlight. For example, you have a patient wherein you have seen an ulcer and you think it could be benign, but still you think it is better to bring the patient after a fortnight after giving anti-ulcer treatment. Better you keep a note of that patient, try to recall, because if the patient is symptom free, he may not come back to you to see you, and after a few months down the line he might come back with a larger ulcer or even a malignant transformation and blame you for not calling him. So, the onus is on us to make a note of all these patients where you need to have some process by which you recall. Like a similar thing I can say, if you have ERCP patient, you put a stent in, and it is our responsibility to make sure you recall the patient or call him by various means like a letter or a telephone call, ensure that the stent is removed. Otherwise, patient will vanish in the dark, come back after a year or two with a cholangitis only to see that stent got blocked. So, those situations patients are always right, you have to have a process by which you do not have these accidents. The second thing is the missing a lesion. Like a beginner, you may have very poor look at sudden in the upper GI tract. For example, let me tell you, when you pass the endoscopy as a beginner, the posterior wall of the duodenum or the superior duodenal angle, the junction of the first and second part of the duodenum, or in a patient with blood clots or a fluid in the stomach, the fundus of the stomach, or when you rapidly pull the scope, the upper 1/3 of the esophagus, or even the in front of the epiglottis, what I call a malicula. So, these areas can be missed, a lesion there can be easily missed. Even I have seen people missing a small fish bone stuck in the tonsil. So, you have to be very vigilant, get a good history, carefully go in. The areas which you have not examined on the way in, you have to carefully take the scope out millimeter at a time in order to concentrate on those areas. So, that is what beginners will find it very difficult, but an experienced surgeon will be able to teach you all the potential blind spot for you. So, those are the areas I wanted to highlight you, and then get back to the more common procedures. Before we go in, we need to divide why into 3 categories, why the complication happen. It is because of you, the team, not very well experienced. So, that is why lack of experience, that is why I am having this class to explain to you, to improve your knowledge on what are the potential reasons for complications. Second, in the beginning you do not take the high risk procedures like these things, and next of course is try to optimize your high risk patients. For example, if the patient is having a poor control diabetes, control it. If the patient is on, for example, double antiplatelets, unless it is an emergency, you better wait for 5 days, ask your cardiologist whether we could stop either of the drugs, preferably the clopidogrel can be stopped. Aspirin usually will not do any harm in my opinion. If the patient is on warfarin, you may have to stop the warfarin temporarily, see the INR, ensure the INR is less than 1.5, if necessary urgent case even you may consider FFB, then pre-procedure or soon after you may have to put the patient on the heparin. All those things you need to be in consultation with the cardiologist. A diabetic patient should be first in the list. Always you do a glucose examination, especially before and after the procedure. And a patient with a severe dyspnea due to COPD, sometimes you may have to consider doing alternative investigations, or there are ways to circumvent, administering those O2 or awake intubation, or you have to put the patient on a chair, a transnasal endoscopy. There are various other procedures you need to consider in a patient in a COPD. Do not take lightly, because these people can go into respiratory arrest. Coming to the timing of the event, sometimes even before endoscopy, during the drug injection patient get into trouble, or during endoscopy because of your faulty technique, or soon after the procedure patient may have. So, always it is very important to anticipate. For example, every patient after ERCP, you anticipate a suspect possibility of post ERCP pancreatitis. If they have abdominal pain, consider doing a serum amylase post operatively. Second, if the patient has any lesion removed like a polyp, then consider if the patient is having a melena, possibility of post polypectomy bleed. So, all these people have been given a contact number. Please contact us when you have pain, fever or any other problem. So, that is what you need to see. Normally, as I said, anesthesia normally is either a local xylocaine spray or conscious sedation by using a small dose 2 to 3 milligram of midazolam. Very rarely we go in for a propofol infusion especially when you do a diagnostic upper GI endoscopy, but things are different when you do a therapeutic procedures or ERCP, where propofol infusion by presence of anesthetist is very welcome. We do use more stronger analgesics like a ketamine or a fentanyl, especially when you do a painful procedure like a dilatation or a stent deployment. Coming to the other more common or more serious complications like cardiac arrest, bleeding and perforation. Coming to the cardiorespiratory arrest, because you very often you glue to yourself to the monitor, you forget about your patient. Never do that, always keep an eye on the patient. If the patient is very quiet, you have to alert and you have to teach our staffs to be very vigilant, and if the patient goes into something like a respiratory arrest or a cardiac standstill, immediately take the scope out and put the patient supine and just try to have an ambu bag and do a CPR and ask for help. Code blue has to be initiated. So, that is a very, and if you think it is due to something like a drug like a midazolam, then you may have to consider like a flumazenil, which is an antidote for midazolam. And what about bleeding? Can it happen during a diagnostic endoscopy, if you ask me? Yes, can happen, especially if the patient is repeatedly retching. If the scope is in the esophagus, if he is retching, it will be a problem. So, you carefully go in, try to enter the stomach as quickly as possible. Second, unwanted suction repeatedly, the tip can damage the bowel wall, or if the patient is a known case of varix or an ulcer, if you go directly suck those areas, it can initiate the bleeding by dislodging the clot or damaging the mucosa over the varix. Or if you have done too soon a colonoscopy or endoscopy without doing an INR, for example, in a patient with a chronic liver disease with a coagulopathy, it can happen even in a diagnostic. So, these are the things I want to recommend you. So, better adequate insufflation, gentle navigation, that is called never use force, and insufflate and luminal endoscopy, and never go very close to the volcano, what I call like varix. If it is there, gently insufflate, do not do anything unless you have the technique and also the experience in order to do a banding and other things. And always if the INR is 1.5, I think that is a relative contraindication. So, these are the things. Of course, when you do a therapeutic endoscopy like these procedures, one can anticipate bleeding, and there are various things you can consider, and they are beyond the scope of this lecture. Coming to the perforation, which each one of you should avoid happening, especially when you do a diagnostic endoscopy. For example, if you are already at 15 centimeter from the incisor teeth and the scope is not going beyond the cricopharynx, it could be one of these problems. Either it is a Zenker's diverticulum, you are entering the false passage every time, or it is a post-cricoid web in a Plummer-Vinson syndrome, or it could be a case of a stricture due to previous corrosion, or it may be CA esophagus there. So, these are all the problem. Unless you are very careful, you may create a false passage. So, that is a issue. So, it is always very important thing in a simple diagnostic endoscopy is never use undue force, never do blindly. When you are not clear, withdraw and have a look. Try a couple of times. There are one or two technical tips I can give you, like a guide wire guided intubation, things like that. But when you are not happy, best thing is abandon the procedure, call your seniors, there is always another day. So, these are all the things I will say, never take a leap of faith blindly, then you will regret. Coming to the therapeutic endoscopy, as I told in the previous modules, you can go into endoscopy master class in dilatation and stenting. Important rule of 3. If a patient is having a stricture of esophagus, it is about 9 millimeter diameter, for example, you can go up to rule of 3, there is 9 plus 3, 13 size Savary, nothing beyond. If you over dilate, you are inviting trouble. Forceful balloon dilatation, especially when you use any balloon more than 35 millimeter, especially for a pneumatic dilatation, that is inviting trouble. Then polypectomy, also especially when you do a polypectomy of sessile polyps, or if you do a ESD carelessly, there are potential places or poem disaster. So, you should be very watchful, and you need to rely on your expertise and experience. And these are all the other situations, procedure specific issues, like for example, the last thing you have in the case of foreign body removal is not able to remove the foreign body. So, make sure you have the right foreign body retrieval device. You do what I call a dry run, that is rigors outside with a similar foreign body with accessories. If it is working outside, then it will work inside the patient's gastric cavity. Anesthetic is not optional, essential in my opinion, especially in children. And sometimes you can put something like a hood, a silicone hood at the tip, reverse load it and insert, especially when you consider in the case of a short foreign body. If at all you remove a short foreign body, the sharp end should be trailing, it should not be leading. So, these are all the few things to avoid any catastrophe. In case of anybody with a bleeding, especially varices, you may nowadays we have something like wonder drugs like terlipressin, which if you give 1 milligram, repeat every 6 hourly, it will reduce the portal pressure and it will minimize the torrential bleeding. And also there are other things available to control the bleeding like a banding. But if the banding is not done properly, or even if you done, if the patient with the multiple unnecessary bands, the band induced ulcer, sometimes it can bleed on day 4 or day 5, that may require a repeat endoscopy and a glue injection. So, these are all the things, and the other thing, small information, especially when you are considering giving a cyanoacrylate glue injection for a fundal varices in a patient. In those situations, if the glue is injected too fast, it may embolize, even causes a stroke in a patient, or it can cause damage to the channel in the endoscopy. So, these are all the issues. So, each technique you need to study carefully what are the potential complications, how you can avoid. Injection, this is one of the commonest procedure as a beginner you may be considering, especially when you have a small oozing ulcer either in the pre-pyloric region or a duodenal ulcer with a oozing, like a Forest classification 1B, preferably a oozing ulcer. That may be the one where you can use 1 in 10,000 dilute adrenaline in 4-quadrant injection, but in spite of that it might continue to bleed. In those situations, unless you have an experience, it is very difficult. So, I always recommend additional combination like a thermal method, like a bipolar diathermic can be used, like coaptive coagulation or hemoclip in some situations. And always, it is always a good principle, 48 hours later you need to come back and then do the examination once more. And coming to the dilatation of the stricture, for example, as I said earlier, when you dilate, when you do not breach what I call the rule of 3, then it will be okay like this, the undue force is not exerted. But occasionally, if the patient post procedure either develop chest pain, they complain of dyspnea, or if they have a tachycardia, or if you put your hand on the neck and chest, they have a crepitus, then you need to suspect. Then consider not only the X-ray chest and also CT with the oral contrast might able to tell you exactly what exactly problem, how severe is the problem, and what we can do to rectify the problem, like putting a clip like a oesophagal clip or a stent and then keep the patient ill orally. So, it can be eminently managed provided we make an early diagnosis. Coming to the another situation where you put a like a self expanding metal stent as a palliation for a CEO esophagus, in these situations, and people can get into trouble like a stent migration or a tumor ingrowth, all those things. Especially the stent migration is very, very important in the first 1 or 2 days, and also if you do not give the proper dietary counseling, they eat like normal person, end up having a stent obstruction. So, you need to tell them you need to take only the liquidized diet, and every time after taking the liquidized diet, you have to be washed down by an effervescent drink, and you need to sit erect for at least for a few minutes, if not hours, and especially if the stent is going right across the OG junction, they preferably sleep in a slightly semi recommend or upright position. So, these are all the simple but very, very important advice you may have to give. Ladies and gentlemen, in spite of all these things, when you get into major complications, I think the very important thing is to recognize them early, go for prompt action, explain to them why it happened, do not run away from the problem, face the problem, be present there, be frank, truthful, compassionate care, and then communication, documentation. They are the two keys to the success. Do the appropriate investigation, always seek the help of the seniors, because they are going to diffuse a crisis for you, and always audit your outcome. If there are increasing incidents of one particular complication, try to do an audit of the whole department and see how you can reduce this issue happening again and again. So, ladies and gentlemen, I wish you had a copy of this, either of this book, and read this to have more knowledge, and my intention is to teach you in such a way that you minimize the chance of getting into all these complications, especially in your beginning of your career as an young endoscopist. For that, good luck. Thank you.